a consultant radiologist with the Rivers State University Teaching Hospital in Port Harcourt, Rivers State. Indeed, she is a former Chief Medical Director of the hospital. Please put your hand together for her as she comes forward. More applause, please. Put your hands together for Dr. Olukumi. Thank you. As a rapporteur with her today, we have Dr. Tomi Owokwetu. She's a hospital consultant and a public health physician at the University College Hospital, Ibadan. Trained at University of Ibadan with an MSc in Global Health and has certification in tobacco control from Johns Hopkins, and consults for national agencies and non-governmental organizations. Please put your hands together for Dr. Tomi Owokwetu. Thank you. So for this session, we have 4 presentations, 4 physical presentations. I will hand over to the chair.
Good afternoon, delegates. We are all welcome to this. This is a third scientific session for today. And it's after tea break. I hope we will not drift off. So we have 4 presenters for this session. Please, are all the presenters here? Please come to the front. Dr. Ditari Adebisi, Ajike PT, Ilori T, and Rima Munra GN. Okay, at least we have the first 2 here, so we'll start. The first presenter is talking on postpartum depression in women attending the postnatal clinic of the University of Port Harcourt Teaching Hospital in Rivers State. And the presenter is Dr. Ditari Adebisi. A round of applause, please. Let's encourage them.
Good afternoon, Madam Chair. All protocols duly observed. Good afternoon, everybody. My name is Dr. Ditari Adebisi. I'm a consultant family physician working in the Federal Medical Center in Agua. And today I'll be talking about postpartum depression in women attending the postnatal clinic of the University of Port Harcourt Teaching Hospital. Okay. Thank you very much. So this work was born out of the passion I have for mental health, especially in women, and some, I wouldn't call it experiences, but a few people I know that actually had postpartum depression and postpartum psychosis informed me to do this study. As we all know, pregnancy comes with many changes, not just physical changes, but also emotional, psychological changes as well. And there are some highs and some lows. Physiological changes may lead some mothers to be at increased risk of developing mood disorders. Women generally are said to have more mood disorders than their male counterparts. And it's believed that hormones play a role, especially women in the reproductive years. So these disturbances, this risk factor may be further aggravated by pregnancy because of the hormones, and then could lead to also mood disorders. The disturbances can also be aggravated by adverse social circumstances. There are many studies that have said that women in low and middle income countries have more chances of developing postpartum depression because of their situation. So where you have low educational status, where you have no jobs, where you have poverty levels very high, then that's a situation where postpartum depression may develop. So with a lot of resources spent on pregnancy-related deaths in low and middle-income countries, postnatal care, especially as it concerns mental health, still has some catching up to do. We are more focused on preventing maternal mortality. So much resources have gone into preventing postpartum hemorrhage and things like that. But mental health is still taking a and I think it should be brought forward. Next slide, please. Now, there's a difference between postpartum blues, postpartum depression, and postpartum psychosis. For postpartum blues, the symptoms, low mood, loss of interest, difficulty in sleeping, loss of energy, develops usually a few hours or a few days after the woman has put to bed. But it doesn't last for more than a week at most times. For postpartum depression, these symptoms are there, but they last more than 2 weeks and beyond. And then for postpartum psychosis, you still have the same symptoms, but there is some psychotic features also interlaced with it. Features such as delirium and hallucinations. Postpartum depression has been described as a public health concern because women who have this condition find it very difficult to bond. Can you hear me? Women who have this find it very difficult to bond with their babies, and that can adversely affect that child growing up. And so it is described as a public health emergency. Worldwide, the prevalence is said to be between 10 and 19%. And of course, socioeconomic settings, like I said before, also plays a role there. In Africa, however, prevalence is pegged at 15 to 57%. You would agree with me that that's a very high prevalence rate. And the reason for this is not far-fetched. We know we live in a country or in a continent plagued with poverty and lack of access or reduced access to healthcare facilities. Promoting mental health and well-being by 2030 is one of the targets of the Sustainable Development Goals, the Goal 3, and that is one of the justifications for this study, together with the increased prevalence. So women, especially those living in resource-poor and developing countries like ours, are more susceptible to developing mental health problems. Next slide, please. So the aim of this study was to assess postpartum depression in this cohort. We wanted to determine the prevalence as seen in the postnatal clinic, and because University of Port Harcourt Teaching Hospital serves as a hospital that actually caters to many other states in the South-South, we felt that was a good place to actually carry out the study. We also wanted to determine the socio-demographic, obstetric, medical, and other factors that may be associated with postpartum depression, and then to determine the level of social support these women have, and if this supportive role is associated with PPD in any way. Next slide, please. The study area was a hospital. It was a descriptive cross-sectional study. All adult women that were consented from their 6-week postpartum were included in this study. The sample size calculated was 216 respondents, and the systematic random sampling method was used. An interviewer-based questionnaire, next slide please. An interviewer-based questionnaire was used, and that was because on starting out the study, we didn't know the kind of social demographics we would have. And we felt that if the questionnaire is actually issued by somebody who understood it, it would be better, the response would be better. So the questionnaire contained questions regarding social demographic factors, obstetric factors, psychiatric factors, and other factors such as domestic violence, if you had a role to play in this, were also included. The MSPSS, also known as the Multi-Dimensional Scale of Perceived Social Support, was the tool of choice for family and social support. The Patient Health Questionnaire 9 was the tool of choice for screening for depression. And it's a validated tool that has been used several times in many studies that had to do with depression. Data analysis was done with SPSS 23. Chi-square was used as test of association, and odds ratio for the strength or measure of association. Now, the results we got, 77% of these respondents had tertiary education, and this was pleasantly surprising, probably because the hospital is an urban area, maybe. The mean age was 31.36 plus or minus 5.12 years. 50%, that's half of all respondents, actually belong to the upper social class. Another surprise for us there. Now, the scale that was used for this was a scoring factor by Olusonya et al. That scored social class based on the education status of the woman and the occupation of the husband, and that was what was used to get the social class. So half of the respondents belonged to the upper social class. We found out that there was no association in this cohort between socioeconomic class and postpartum depression, telling us that anybody can actually have postpartum depression, the well-to-do and the not so well-to-do. Next slide, please. So the prevalence we got was 27.3%. We had 72.7% with no depression, 16.2 with mild depression, 8.3 with moderate, 2.8 with moderately severe. We didn't see anyone with severe depression. So the depression in this case was divided into mild, moderate, moderately severe, and severe. And thankfully, we didn't get any with severe depression. So prevalence of postpartum depression was 27.3%. Next slide, please. Now, other things we found out concerning the factors associated with postpartum depression. We found out that those who had a history of pregnancy loss were about had two times the odds of developing postpartum depression. That pregnancy loss could have either been a first, second, or a third trimester pregnancy loss. We also found out that those who planned their pregnancy were less at odds of actually having postpartum depression. So those who had unwanted pregnancies or pregnancies that were not planned for were more predisposed to postpartum depression. Also, those who had presence of postpartum complications, in this case, the complications that were considered were febrile illness and postpartum hemorrhage and others. So those with postpartum complications were more at odds, about almost 4 times at odds of developing postpartum depression. And then women not exposed to domestic violence were less at odds of having postpartum depression. For the medical conditions, the chronic medical conditions considered were hypertension and gestational diabetes, some type 2 diabetes. We found out that those who had these chronic medical conditions had more chances of developing postpartum depression. And then those who also had a family history of mental illness were had up to 4 times the odds of developing postpartum depression. Next slide, please. For perceived level of social support among the respondents, we used the MSPSS, like I said before, and that tool actually measures support from significant other, which are the partner or the husband, support from family, and support from friends. As you can see from the bar chart, many people had good support. 88.4% had good support from their spouses, same with family, and a little bit lower for friend support. Now, family and social support goes a very long way in curbing the incidence of postpartum depression. So the Omugwo tradition that we have in Nigeria goes a very long way to help. When a woman has a baby and the mother comes in to help, it goes a long way to prevent symptoms of postpartum depression from coming, and it's something that is highly encouraged. Next slide, please. So from the results we saw, we discussed further about women with women with higher educational level making better use of postnatal services. And so education plays a key role in this. So maybe more advocacy should be placed on actually encouraging people or educating them about the benefits of postnatal services, because some people may come to the hospital, have a baby, and then disappear afterwards, not knowing that this is also a very important part of their maternal care. Prevalence of postpartum depression was same as seen in another study still done in the South. So this study had 27.3. Another study done in University of Benin Teaching Hospital had 27.2. So pretty close. And so we know that this may actually be the prevalence rate for this particular disease entity. 31% of Nigerian women are said to suffer from domestic violence. In this study, we got 10.2 of the respondents saying yes, there was some form of domestic violence. The tool that was used there was the HEAT. I forgot to mention that earlier. So we asked them whether they were hurt, insulted, threatened, or screamed at. HEAT questionnaire. That was what was used. But we feel that this rate of 10.2 may have been more if we had used a self-administered questionnaire rather than an interviewer had administered. And then, of course, mothers with chronic medical conditions like diabetes were at increased risk. So I brought this out just to say that postpartum depression can actually be screened for in our postnatal clinics. Once you see a woman has, even in the antenatal clinic, once a woman has a history of domestic violence or even has a history of chronic medical condition, she should be penned down for possible postpartum, and care should be given to her to prevent that from happening. Next slide, please. And so the takeaway is that risk factors can be easily identified during antenatal visits. Screening for postpartum depression in postnatal clinics is highly recommended and can really easily be established. Family and social support given to new mothers, please don't let it stop, very important. Primary care doctors should also have a high index of suspicion for PPD and ask targeted questions when you see that woman in your clinic. That can go a whole long way to solving that woman's problem and preventing that disharmony between mother and child. Finally, advocacy for mental health should be scaled up. It shouldn't be a corridor conversation anymore. It should be a boardroom conversation. We should normalize talking about mental health. Thank you very much. Back to you, Madam Chair.
Thank you, Dr. Adebisi. Please, we have 1 hour for this session, and we have 4 presenters. So each presenter will be given 10 minutes, and we will ask all the questions together so that we, at the end of the presentation. So if you have a question, please note it. And at the end of the presentations, we will ask the questions so that we can make good use of our timing. Thank you. So I'll call on the next presenter, Dr. Ajike. The topic is prevalence and determinants of spousal abuse during COVID-19 pandemic experience among a sample of women in Abeokuta in Nigeria. You have 10 minutes. When it's 8, I will give you warning. Thank you.
I'm Ajike from Federal University of Agriculture, Abeokuta. And like she rightly said, I will be talking about prevalence and determinants of spousal abuse amongst a sample of women in Abeokuta. Sorry, that's my slide. But then I'll go ahead. Spousal abuse defined by WHO as a physical, sexual, or psychological coercive act by a current or former or spouse to a woman. Spousal abuse has increased during the COVID-19 crisis across the globe, remarkably in Africa, as said by Duncan et al. Now, according to a WHO report, COVID-19 pandemic restrictions have created an opportunity for violence against women. For example, the government's stay-at-home order and closure of workplaces may have indirectly forced women to spend more time in their homes and ultimately expose these women to increased spousal abuse by their partners. This scenario is supported by CDC reports, which states approximately 1 in 4 women report experiencing any form of spousal abuse. Also, there have been reports of case scenarios, including descriptions of many forms of intimate partner commonly reported, including economic, psychological, and often currently. These reports have also highlighted how the lockdown disrupted women's social support, hindering their accessibility to formal and informal sources of help. An article by WHO reported that 1 in 3 women worldwide have experienced either physical or sexual violence by intimate partner or ex-partner. Sorry, it's still, I'm sorry, I don't know who's in charge of the slide, but that's not my slide. Yes, I submitted my slide. I don't know what's wrong. Ajike. So the statement of problem, during the COVID-19, increasing rates of domestic violence are beginning to surface. And it's been said that this is only a tip of the iceberg. Notably in China, domestic violence, spousal abuse has tripled during the stay-at-home and order by the country. This universal trend on the increasing domestic violence cases is likely to continue throughout the pandemic. The United States also issued a warning on intimate partner violence due to the increasing novel coronavirus. Sorry, I think I'm a bit disorientated because of the slides. I'm actually looking forward to it. Now, yeah. No, it's not my flash, I'm sorry. So, pandemics, financial insecurity, stress, and uncertainty have led to increased aggression at home, which was seen previously with the global financial crisis in 2009 and natural disasters such as the one in 2011 Christchurch earthquake, with abusers able to control large amounts of their victims' daily lives. Spousal abuse also increases whenever families spend more time together, as said by TAO 2020. And as stated by the French Secretary of Equality, Marlene Schiappa, confinement is a breeding ground for domestic abuse. Now, this extreme stress and uncertainty and fear is accompanied by emergencies and disasters coupled with social isolation, movement restrictions, have raised concern for increases in family and domestic violence. to date, the majority of literature and studies on COVID-19 and violence has been released through commentaries, organizational reports, and news sources. Evidence from the previous pandemics and emergencies has identified that the most common factors that increase the risk for violence include economic insecurity, poverty-related stress, job loss, or reduced working hours, quarantine, and social isolation. Sorry. Okay. Now, the objectives of this study. The objective of the study was to describe the socio-demographic characteristics of the respondents within Abeokuta North local government, and to determine the level of physical violence victimization during the COVID-19 pandemic, to identify the sexual violence against women during the COVID-19 pandemic, and then to ascertain the extent of psychological abuse during the COVID-19 pandemic among respondents in Abeokuta, Nigeria. Now to the methodology of the work. A cross-sectional study was done. It was a cross-sectional study that was designed, survey design, that was used to investigate the prevalence and the determinants of spousal abuse during the COVID-19. The study was carried out in Abeokuta, the state capital of Ogun State in southwest Nigeria. Thank you very much. And then a multi-stage sampling technique was used to determine the respondents that was used. A sample size of 383 was calculated using the single proportional method of sample size. The research instrument that was used was a COVID-19 pandemic and spousal abuse questionnaire, which was adopted from, which had 4 sections. Section A was to measure the socio-demographic characteristics of the respondents, the family factors, husband factors, as well as the maternal, the women the mother's factors, that is the females, their own factors too. That is the respondent, sorry. Section B had 16 questions that was adopted from the Physical Violence Victimization Questionnaire by Foshi et al. 1996. Section C involved 6 items that was adopted from Sexual Violence Against Women Questionnaire. And the last section, Section D, had 23 items for measuring psychological abuse that was adopted from Index of Psychological Abuse Questionnaire. The questionnaire was an interviewer-based method of collecting the data from the respondents. The data was analyzed using the statistical package for social sciences, 23, and using descriptive statistics and inferential statistics. Now, this is a table showing the socio-demographic characteristics of the respondents based on the results. The mean age for the respondents was 39.4. Majority of the respondents were Christians, and majority were educated, with about 61% 61 of the respondents, 50.8 of the respondents having an SSC. Of course, because it was done in southwest Nigeria, you have majority of the respondents too who were Yoruba speaking, of the Yoruba speaking tribe. The majority of the respondents, about 366, sorry, because of the limit on the slides of the tables could be put on the slide. So about 366 of the respondents were married, and we had about 4.9% of the respondents were cohabiting, and they were single. Majority of the respondents were they had been married for less than or equal to 10 years in marriage, and you had majority were living by themselves. Next slide, please. So the results also showed that prevalence of spousal abuse in the study, there was a prevalence of spousal abuse in the study, a prevalence of 30.1%. This is a bit higher than the study of Tadei's 2020, which was done in Ethiopia, that had a percentage of 24.2, with psychological abuse as the most prevalent, 19.5%, and followed by sexual abuse, 7.5%, and physical abuse, 3.9%. The study was established that there was a statistically significant association between the social demographic characteristics of the respondents, their own factors, which was their age, the religion, educational level, and the occupation of the respondents. So the study concluded that the prevalence of spousal abuse was relatively high as compared to other studies in existence, and as a result, it is, however, recommended that public reporting of any occurrence of spousal abuse, it was recommended that there should be public reporting of occurrences of spousal abuse, and is also crucial, which is crucial to reducing the problem, as well as family counseling and couple therapy is also one of the recommendations for this study. Thank you.
Thank you, Dr. Ajike. Please, let's give her a round of applause. You can see that she honed her own presentation. Even when there was problem with the multimedia, she was still talking. Thank you so much. So we go to the next presentation, and we'll be having Dr. Ilori T. She will be talking on self-medication, practices and barriers to accessing formal health care among the undergraduate students in Nigeria University. You have 10 minutes to the presentation.
Good afternoon, all. My name is Temitope Ilori. I'm a consultant family physician in the University College Hospital and a clinical lecturer in the University of Ibadan. Today, I will be presenting our findings on study, self-medication practices, barriers to accessing formal health care among undergraduate students in a Nigerian university. Yes. As a background, self-medication is defined by the World Health Organization as the use of medications, using one's own initiative without actually consulting a medical practitioner. It is very common in our environment for the simple fact that drugs are prescribed or are sold over the counter without necessarily having a doctor's prescription. Studies have shown that this is actually commoner among the youth, the younger generation. And we felt we should assess the practice amongst our medical and nursing students, because they are the next generation of prescribers, and know what they actually practice and what their barriers are in terms of accessing health care. Next slide, please. It was a cross-sectional study. It was amongst 303 medical students and 116 nursing students, all recruited during their clinical posting in the University College Hospital. A self-administered, structured questionnaire was used, and this was used to collect data on demographic, social demographic data, collect data on perceived health status among the students, the common illnesses they observed and they reported, their self-medication practices, and also their identified barriers to accessing formal health care. And this data was analyzed using descriptive and bivariate analysis. Next slide, please. This table shows us the social demographic characteristics of the respondents. The mean age was 23 plus or minus 3 years. Females accounted for about 53% of the respondents were female. 72.6% of the respondents were medical students doing their clinical posting. And about half of the respondents actually had a monthly allowance of less than 20,000 naira. Next slide, please. This table was to show the common physical and psychosocial issues reported by the respondents. About 15% of the respondents actually reported headache, as a very common ailment that they experience. About 27.4% of the respondents said they had stress, that they experienced stress as the most, very often. About 10% of the respondents gave anxiety, took anxiety as one of the illnesses they experience very often, and about 4.5% of them actually had depression as one of the most common physical or psychosocial issues they had. Next slide, please. Yes. This table was to tell us about the practices of self-medication among the respondents. About 50%, 50.5% of the respondents had actually resort to self-medication, you know, as a first step when they are ill. Just about 20% of them will visit a physician, and about 15% of them will take no action at all. 3.4% of them reported that they consult the internet for possible diagnosis and treatment when they fall ill. 65.9% of the respondents actually alluded to the fact that they actually self-medicated 12 months preceding the study. They actually self-medicated, and yes, we had this question that asked about their agreement, how they felt about medication among students, and about 30% of them actually agreed or supported self-medication. The other 30%, well, were not in support, disagreed to it, and about 30% of them were actually undecided. About 35.9% were undecided about either or not to support self-medication among students. Next slide, please. There were questions around barriers to access the health services. Quite a significant proportion of the students alluded to the fact that prolonged waiting time at the clinic, lack of time to go to school clinic were some of the factors why they resorted to self-medication. There were some concerns about confidentiality in about 24.3% of the patients, and some said stigma of visiting the school clinic and all were some of the barriers that prevented them from visiting the school clinic. Next slide, please. Next. This was to assess their perceived health status, and very few of them, less than 0.1% of them, actually had poor health status. Most of them had at least perceived their health status to be good, very good, or excellent. Next slide, please. This was the chi-square to determine the association between the socio-demographic variables and self-medication, and there was a significant finding between the level of study and socio-demographic, between the level of study and self-medication, a p-value of 0.009 was found. However, other variables were not significantly associated with self-medication. Next slide, please. So in conclusion, I want to say that this study actually reviewed the high prevalence of self-medication, as has been alluded to in other studies that were reviewed, and that the part of the reason given was the barriers to accessing formal health care in terms of time factor, stigmatization, and confidentiality of the health workers. And therefore, there is a need to actually, have some training for our upcoming medical and clinic and nursing students on the need to avoid self-medication because of the risk factors of drug resistance and other ills that are associated with these practices. So I thank you for your attention.
Thank you, Dr. Ilori, for your presentation. We'll take the fourth presentation, and it will be virtually this time. We'll take it from Dr. Grace Rimanura. She's presenting online, and she's presenting a paper on factors that influence parent-adolescent communication on adolescent sexual reproductive health. She's talking from Benue State. Dr. Grace, you have 10 minutes.
Okay. Good afternoon, Ma. Good afternoon, everyone. Please, can you see my screen?
No, but we can hear you.
Okay.
Yes, we can see.
Okay.
You can go ahead.
Thank you for this opportunity. I'll be presenting factors that influence parent-adolescent communication on adolescent reproductive health in Benue State, Nigeria. I'm Grace Rimamnora, presenting on behalf of the other authors, and I'm a public health physician, consultant public health physician with Benue State University College of Health Sciences. So I'll be presenting with the following outline: introduction, study objectives, materials and methods, results, conclusions, recommendation, and references. As a way of introduction, the communication between parents and adolescents on adolescent sexual reproductive health is really vital for tackling the rising issues on adolescent reproductive health. And you agree with me that many adolescents are getting the wrong information from social media, from their peers, and this has resulted in inaccurate information and then with the negative consequences in their behavior. However, parents have been said to be a very good means of communication, in the sense that some studies have shown that parents, whenever they engage in communicating with their adolescents on sexual reproductive health, such adolescents have been found to delay their sexual debut. And despite this important information, parents and adolescents have some factors that restrain or constrain this communication, such as the age, gender, marital status, educational attainment, and religion. They often influence this parent-adolescent communication. And also, cultural taboo, as you agree with me, is one of the major factors from previous studies around this area. This study was conducted in Makurdi and Boko local government area of Benue State from May 2019 to June 2020. And it's a cross-sectional study that was carried out among junior and senior secondary school students in 3 schools from each of the 2 local government areas. And the students that were used were those that were within the age range of 10 to 19 years and consented to the study. The sample size was determined using the appropriate formula, and a sample population of 250 students was obtained. So what we did was to use 250 students from each local government area with their parents, so giving us a total sampling population of 1,000 people. For obtaining the different stages of the sampling was used, a multi-stage sampling technique was used, and quantitative and qualitative data were collected. For the quantitative, we used a pre-tested structured self-administered questionnaire, whereas for the qualitative data, a focus group discussion was done respectively in each of the schools. Ethical clearance was obtained from the Benue State University Teaching Hospital, the Health Research Committee, and the school authorities, and also from the parents. For the results of this study, the study revealed that parents' gender was found to influence the parent-adolescent communication positively, as this study showed that more of the fathers, with the attendant percentages are shown on the screen, more of the fathers communicated regularly. In this context, regular was measured by daily and weekly conversations with their adolescents, whereas the mothers had less regular conversations with their adolescents. Now, this was what attributed for this from this study was the fact that around this area, more males were seen to be educated than the females. And also, this study found that parents with tertiary level of education engaged more regularly in parent-adolescent communication in both local government areas, and those within 30 to 50 years age group were more regular in their communication than the older parents in both local government area. For the tertiary, it was actually, this could be explained by the fact that most of the parents, their level of education was more of the tertiary attainment. So that could account for this. And then for occupational factors, it was found by this study that those who engage, the parents who engaged in farming and fishing were more likely to engage in parent-adolescent communication than those in other occupations. However, from this study, we found that more people around this area, the Benue State area, engaged in farming. And so that could account for this increase. And then for the results from the focus group discussion, it showed that fear of experimentation and cultural beliefs reduce parent-adolescent communication, as most parents felt that when they begin to talk about those sexual issues with their adolescents, it might push them into wanting to try out. So that was the finding from the focus group discussion. In conclusion, this study showed that the proportion of parent-adolescent communication on sexual and reproductive health is affected by parents' gender, their level of education, occupation, cultural belief, and fear of experimentation. This had a significant association with their communication. We therefore recommend that it's important that health education on parent-adolescent communication should be amplified in schools, hospitals, religious institutions, social media, in order to create awareness on the positive impact of this kind of communication on helping to curb the effects or the issues surrounding adolescent sexual reproductive health. These are the references. Thank you very much for listening.
Thank you for your presentation.
Thank you, ma'am.
Okay. So you stay by because some people will have questions for you.
Okay, thank you, ma'am.
So we'll be having a 5 minutes recap from the repertoire, Dr. Owokwetu.
Thank you very much, Ma. And good afternoon to everyone seated. Thank you for listening. We had the first presentation from Dr. Adebisi, who talked about postpartum depression in women attending the postnatal clinic of the University of Port Harcourt Teaching Hospital. And she laid a proper introduction on how pregnancy can aggravate psychological highs and lows, especially due to the hormonal changes, as well as the differences between postpartum depression and psychosis, and also highlighted the high prevalences that are experienced in Africa, and also showed us how there was no association between postpartum depression and socioeconomic status in our study. And the prevalence of postpartum depression was quite high in our study, 27.3%. And she told us about factors that tended to increase the experience of postpartum depression, including prior pregnancy loss, postpartum complications, and a family history of mental illnesses, and also having a history of chronic medical conditions like diabetes mellitus. And she concluded by telling us that women with high educational levels usually use postnatal services. Those are the women that are more likely to go back to the hospital after they've delivered. And we should use the postnatal clinics that operate in our centers as an opportunity to educate and also to screen for likely psychological issues like postpartum depression. Then we went to another excellent presentation on prevalence and determinants of spousal abuse during COVID-19 pandemic experienced among a sample of women in Abeokuta, Nigeria, by Dr. Ajike, who talked about how the lockdown and the stay-at-home policies had, in some way, forced some women to be at home more than they usually would be, and even inadvertently exposed them to spousal abuse. She also quoted global figures from China to America, which also showed that this is an increasing trend and is likely to persist throughout the pandemic. The prevalence of spousal abuse in our study was also quite high, 30.1%, and psychological abuse was said to be the most prevalent. She recommended public reporting and family counseling and therapy in addressing this matter. Thirdly, we went to Dr. Ilori, who had a wonderful presentation talking about self-medication practices and barriers in accessing formal health care among undergraduate students in a Nigerian university. And she told us, laid a foundation about how self-medication is a part of self-care, but should be done with caution because of the risk of resistance and also abuse of medication. And the study was done among medical and nursing students, which was really nice because they are the future of healthcare. And they asked them about common illnesses. They were able to chronicle common illnesses among them, including headaches, abdominal pain, for some of them depression. And up to 50.5% of them were said to self-reported self-medicating. And only about 20.6% of them would visit doctors. And in the last 6 months, 65.9% of them had self-medicated, which was quite high. And she talked about the barriers to their visiting the hospitals for treatment, which included prolonged wait times, not having time because of their schooling, and the issues surrounding confidentiality, potential stigmatization that might occur if they were seen coming out of those places or known to be on medication. And she talked about these high prevalences. We need to address the barriers, improve access for them, especially to be able to access the care that they require. And it's also important because I think that as the future of healthcare, they need also to not just learn about medicine or nursing, but to be able to self-face the education that they are receiving to themselves and apply it, first of all, to themselves. The last presentation was regarding factors that influence parent-adolescent communication on adolescent sexual reproductive health in Benue State, Nigeria. And she talked about parent-adolescent communication and how it's vital, and also how it's important in influencing and shaping the adolescent, and talked about the barriers, which we all know, cultural taboos, the risk of embarrassment on both sides, lack of prior communication between the two parties already, and then the religious and traditional beliefs that are already in place. She also told us about their gender. Parents' gender, from our study, parents' gender influenced the communication that happened between them. And in Benue State, more fathers were seen to communicate more regularly with their adolescents. And she gave the possible reasons why this was happening, especially because they were probably more educated and were more ready to take on such conversations. And then parents that had tertiary education were also more engaged in parent-adolescent communication. She listed major barriers to this kind of communication, especially regarding sexual matters and sexual and reproductive health, as barriers that are already documented in literature, cultural beliefs, and the fear of experimentation. The parents don't want to engage in these conversations, and then the adolescents just take it on and go to practice what they are hearing. These were very excellent presentations, and we thank everybody for giving us such rapt attention. I'll hand over back now to the chair. Thank you, ma'am.
Please, can we give the presenter another round of applause? Thank you very much. We'll go to, thank you, the reporter, Dr. Wipetu. So we'll go for question and answer. Please, if you have question, you can just raise your hand so that you can. Thank you, Prof. Prof, I think you can come. We can start with Prof.
The chair. Let me thank the research or scientific committee for these excellent papers. I'll start with PPD, postpartum depression. I would like to know, did you explore into alcohol and drug use prior to that pregnancy? Because when you are pregnant, you are discouraged from using alcohol. Some are on anxiolytics and will probably not use it during pregnancy. So would that affect them after delivering the baby? Because they're used to some alcohol and some drugs. Secondly, for the PPD, any reduction in family support because of COVID. I think some of us who have children outside the country, some of us do go to assist them. But now COVID is, I think, is curtailing such trips. So maybe the lady studying PPD, you may also wish to look into that. Can I go on to the second abstract, ma?
Yes.
Okay.
Just ask all the questions.
Okay. The one on spousal abuse. You know, during the lockdown, there is a decrease in family income. Did you explore the family income pre-COVID lockdown versus the income during COVID? Because what causes a lot of family disharmony is reduction in the earning power of both husband and wife. Self-medication is by Dr. Elori. It's an important work, but I don't think I had the drugs, the specific drugs that they were self-medicating on. I think that is very helpful to us if you have information on that, the common drugs. Then the last abstract, I must commend you because you are the only one that mentioned ethical clearance. I think when we are presenting, particularly in international conferences, please let us know if you had ethical clearance. I would suggest to, your presentation, the fourth abstract on adolescents and communication on reproductive health, to make meaning out of this work. It would be nice if you can produce like handbills that will guide the parents in asking specific questions. It's not easy to dialogue with your teenage children. I think all of us understand what I'm saying here. But if you have a structured questioning or questionnaire in form of a handbill, both in English and in their local language, I think that could help. Thank you for the opportunity.
Any other question, please? Please, if you have a question, just come forward. In the interim, Dr. Ditari, you can answer the questions. Just come, just sit down.
All right. Thank you very much, Ma.
Okay.
So for the alcohol and drug use before pregnancy, no, that wasn't part of the risk factors that were explored. But I agree with you that that could have been important, especially as DSM-5 now says postpartum depression has a peripartum specifier. So if we had asked about drug and alcohol, either during pregnancy or before pregnancy, we will know that during pregnancy there will be some withdrawal, right? And that can actually even lead to postpartum depression. So that's a very good one to note, Matt. Thank you for that addition. Then during COVID, family support, if there was any reduction in family support, this particular study was done pre-COVID, just pre-COVID. So that part wasn't explored. And then for the ethical clearance bit, yes, I did have ethical clearance from the board of the hospital as well as from the Department of Obstetrics and Gynecology. Thank you, ma'am.
Dr. Ajike, you want to?
Thank you, ma'am, for the questions. It was a very nice question. It was a good question and observation with respect to their family income pre-COVID and post-COVID. However, we did not explore their family income pre-COVID, only their family income as at the COVID, the pandemic period was explored. But I totally agree with you that that was a good point. So we accept it as a limitation, one of the limitations of the study. And as with respect to ethical clearance, yes, ethical clearance was sought. Informed consent of the participants was also part of the ethical clearance that we also sought before carrying out the study. Thank you very much.
Thank you very much, Ma, for the observation. Yes, sorry for the omission. We did have ethical clearance from the University of Ibadan UCH Ethical Board. Yes, the most commonly abused drug were anti-malarials. About 72% of the respondents actually said they are taking, or they do take anti-malaria without any confirmed blood film for malaria parasite, just empirically. And then 61% of them also abuse analgesics. Once there's a headache or something, they do take, and about 29% said they are taking antibiotics in the preceding 12 months before the, without any form of investigations to actually confirm they had such infections or not. Thank you, ma'am.
Thank you. I think we just ask the other questions. Our time is...
Thank you to the presenters for the wonderful presentation. My name is Dr. Vivian Ubunna. My question goes to the presenter on parent-adolescent communication. You did mention that you obtained consent, but I was wondering if you could give an insight as to how you got consent from those who are less than 18 years, because you said it was in school, and then the consent should be from their parents, and they should give assent. So I wanted to hear that, but I didn't. So I wanted to provide insight to that. Then also to give us an insight on how you selected the participants for the qualitative aspects of the study. Thank you.
Thank you. Dr. Ogbonna, please. Please introduce yourself.
Thank you very much, presenters. My first question goes to the...
Please introduce yourself.
Yes, sorry, I'm Dr. Salawu from IBADAN here. The first presenter that spoke on postpartum depression, you said you calculated your social class using the respondent education and the husband's occupation. So I was wondering why you did that. Since I think the woman must have been working before she was admitted in the hospital, and I think the correct calculation for social class is to use the participant or the respondent education with his or her occupation. So I was wondering why you calculated it that way, or was it that she wasn't working? And also, even if she wasn't working, I think that could actually constitute or contribute to the depressive state. Then my other question goes to the third presenter, Dr. Ilori. Yes, I was wondering why we have the high prevalence of self-medication among medical and nursing students, because most of them reside, if they within UI and maybe in UCH. So they have, and you said one of the barriers is access to health care. So I was wondering what's the lack of access that they have there. Jaja is right beside them there. UCH is there. So is it that they can't, I think you should have explored, more about, why exactly, don't they want to go to Jaja? Is it because of the timing? Maybe they waste a lot of time before they attend to them, and like that. And Prof has also mentioned the drugs, and I think you have answered. Thank you.
Thank you. Any other questions? We also have 2 questions online so that the presenters can take it up. Then we'll round up. To the first presenter, is respondent's occupation correlated with spousal abuse? Did professional women suffer more abuse from your findings? The other question is, did you get the question, Dr. Adebisi? Is the respondent's occupation correlated with the spousal abuse? Did professional women suffer from more abuse from your findings? The other question is for presenter 4. Dr. Grace, are you online? So you spoke,
yes, ma'am. Yeah.
Okay. You spoke more of father-adolescent communication. Was it father-son or father-daughter communication?
Okay.
Person said it's important you specify on that.
Okay, can I go ahead?
Yes, please.
Okay, ma. It was actually not specific whether father, son, or father, daughter. It was just what we sought to get from the parents was if they communicated with their adolescents, whether son or daughter, but we did not specify. And also, somebody asked about the consent. We took consent from the school and then from parents, and even down to the adolescents, we still sought their consent for all of them across board. Even for those that were above 18 and those below, we still sought their consent. And for the other comments on addition of the handbills, I find that very useful, and I will include that in the work when it's being reviewed. Thank you very much, ma'am.
Thank you. Dr. Ajike, you can answer.
Thank you for the question. However, with respect to the respondent's occupation for spousal, it wasn't significant. Respondent's occupation was not significant with spousal abuse. Then secondly, the question that was asked was whether professional women suffer more. It was a joint effect of the socio-demographic factors that was tested. However, the suggestion with respect to whether professional women suffered more spousal abuse can also be put into the study upon review.
Thank you. I think we'll just round up now. I want to thank the presenters, and just to conclude, we'll learn that we have increase in people suffering, in women suffering from postpartum depression, the depression, the psychosis, and it's increasing in our society. So I think, like we said, when we go back, for those of us working in that area, maybe we want to work more on this so that we can see if when we have more work on this, we can reduce this depression, especially as we are medical women working for the health of our women. And it will be good that this work is, more work is done on this so that we can help our women. The spousal abuse during COVID, while I was seated, Dr. Wa was saying behind us, a penniless man is an angry man. You are just shouting, when you don't have money, you are hungry. And I think we cannot say that, we cannot attest to that, because the COVID has really dealt with our economic power, and it has caused a lot of problem in the home. Another thing I thought about that is that some of us don't even know ourselves as husband and wife, because when we were all going out, we go out in the morning, you come back in the night to come and sleep. So you are not together, you are not talking, you don't have that much time. But when COVID locked all of us in the house, we were now seeing ourselves for the first time. And then the woman will talk and say, what did I say now? And the man will say, hey, you are talking to me like that. He reply you with a backhand. So it's led to a lot of more abuse, more, especially between spouse. And I think, like she said, there's an increased trend. And people will lose their job, and you are at home. You have never been used to being at home. Now you are seeing the children, the house is dirty. Before you came, they will clear the house and all that. But now you are seeing it. And the woman is saying, you too, what are you doing? So I think all these things is part of the problem that COVID has brought back to us. And the psychological abuse is more. Thank God in this own presentation, the physical abuse is the least from what we are seeing. And the conclusion is that we should prevent, I don't know how we are going to do, to reduce the occurrence of the abuse, maybe when COVID has gone. But we are told that COVID has come to stay. In self-medication, I also wonder if we ask half of us here, apart from the medical students, how many of us we treat ourselves first before we consult even our own colleagues? Before you consult even your own colleague on anything, it's very high. Self-medication is something that we do very high. Yeah. Then I had a question, because even the people that are selling the drugs to us, they said, if you have taken it for 2 days and there is no improve, consult your doctor. So is that self-medication? That's food for thought, please. Because they encourage you to start is when it's not going, the disease is there, that you start looking for a doctor. Dr. Grace, thank you very much for the adolescent reproductive health. This is another area that we know that more works need to be done. And thank you,
Yes,
Prof, for pointing out about the ethical clearance before we do the presentation. I'm sure the next set of presenters will tell us about their ethical clearance before they go ahead. I want to thank the LOC for the privilege to chair this session, and thank my able assistant, Rapporteur, for the good work done. Thank you very much, the presenter, Dr. Adebisi, Dr. Ajike, Dr. Elori, and Dr. I'll call you Grace, sorry, so that I don't crucify your surname. So thank you very much. Okay. Please, can the presenters come forward and we'll take a picture here.
Thank you very much, Madam